Morning, friends.
Morning. I'm with Frank if you want to get started, Dr. Gannon.
Oh, cool. Should we wait for other people? I know it's just barely 7 o'clock, and sometimes 7 o'clock is pretty early for folks to get started. You guys, I know, are around really early, so maybe you're already like halfway through your day, but I'm happy to wait if you feel like other people will be joining us.
Sure. You want to give it a minute?
Mike and Doreen should be coming in.
Cool. Okay, it's about 3 minutes after. Are you guys okay if we go ahead and get started? I want to make sure that we have time for questions at the end too.
Sure, go ahead.
Cool. I think this is being recorded, so if you're opposed, pop off. If not, I think it's actually really helpful so that if you have new learners join your team, if you have new APPs, you can actually just hand a lecture to them to review if you think that it might be helpful for anybody else. I'm happy for you to spread this to anybody who you think it could be useful for. So I'm Kim Gannon. I'm one of the neurologists here at Christiana, and I'm super excited to be talking to you guys this morning about the neurologic exam of unresponsive patients and a couple of stroke syndromes. This is something that we see, unfortunately, far too frequently and often in people who have post-traumatic injuries. It makes it more difficult to examine patients just because they're not really able to interact with you the way that you and I would, and they're not sometimes able to follow commands. So I'm really thankful for the opportunity. Thank you guys so much for inviting me. I have no disclosures. The goals for our talk today will be to improve understanding of how to examine a patient who's not cooperative or who is unresponsive, to improve recognition of some anterior stroke syndromes, and also improve recognition of the posterior stroke syndromes. So please stop me. I got the screen up so I can see if anybody raises their hand or starts to talk. So please feel free to pop in anytime during the lecture. If you have questions or thoughts or comments on patients that you've seen recently, we can definitely bring that into the conversation also. So you guys are all familiar with the Glasgow Coma Scale. This is sometimes used in stroke also, but was originally intended for patients who are trauma patients. So you're familiar with this quick evaluation of eye response, verbal response, and motor response. There's lots of other abilities of a patient, but these are things that you can look at really quick, and then an easy way to communicate what a patient's kind of global picture is from one provider to another. In stroke, we often rely on the NIH stroke scale. This goes through a lot of questions, but you can do it pretty quickly and probably under 2 or 3 minutes. This scale is a little bit biased because it takes into account everything that the patient has, whether it's new symptoms or whether it's old symptoms. If you had old left-sided weakness, you still got to get points on your NIH scale for that. So sometimes you can erroneously have a higher score than what the patient is currently experiencing, but it's still helpful to provide information from one provider to the next. So I wanted to start out thinking about cranial nerves, and if we all dig deep back into our brains, we can remember neuroanatomy from med school. And really the way I think about the neuro exam, and especially when I'm dealing with unresponsive patients, is really focusing on each cranial nerve at a time. That'll kind of tell us what area of the brain is not doing what it's supposed to be doing. So thinking through I usually go through sort of in order 1 through 12 to think about how to evaluate these patients. So cranial nerve 1, until COVID, nobody really cared about. Even with COVID, we don't test it. Just sometimes people will tell you off the bat if they can't smell anymore, which can be useful on your exam, but it's not something we test. The old school neurologist used to carry vials of coffee grounds in their black bags when that was a thing, and they would actually test this, but it's not most of the time really clinically useful for making decisions for most of our patients. So we'll start off with cranial nerve 2, the optic nerve. In patients who are able to respond to you, you can do your visual fields and make sure that you can they have a good vision. But in patients who aren't responsive to you, we got to think of other things that we can do for these folks. Sometimes just checking visual pursuit can be enough to tell that they can see you, and you can do that a couple of ways. If they can't count your fingers like we usually would have patients do, you can try to have them follow your thumb. Thumbs aren't very exciting though. So sometimes a patient who has a decreased level of consciousness isn't going to be able to follow your thumb. Even though they can understand and they can open their eyes by themselves, they might not be able to really engage with you enough or pay attention to follow a thumb. So you can have them follow other stuff. One thing I like to do is just move my head in front of the patient. Even though this is something that we think about usually in babies, like recognizing faces and being attentive to faces, people who have a decreased level of consciousness are also much more attentive to faces than they are to thumbs or anything else. Sometimes also it's helpful if you have access to a mirror or your cell phone, you can turn it around and make it into a camera and actually hold that in front of the patient's face. They're much more attuned to their own face and can sometimes key into that and keep their eyes tracked on their face as opposed to your face. Just because you're a new person, they don't know you, but they can recognize their own image sometimes and stay locked onto that. And that's a good way to get to see if they can see you and see if they can move their eyes from side to side. The other thing that you can do if they're not able to track you is blink to threat. Sometimes this can be a little tricky, especially if patients can't open their eyes by themselves. So you'll actually need to passively open their eyes and then rapidly move your fingers in kind of a blade shape toward the patient's eyes. You want to make sure that you're going in with a blade shaped hand. Hopefully you can see my video, but you're going in at like a 45-degree angle from the side like this, and you're not fluffing air in their face with a flat hand. If you fluff air in their face, that actually becomes a corneal reflex because you're testing a different cranial nerve and not necessarily just that blink to threat. So if a patient's not responding, you want to check cranial nerve 2, holding the eyes open and going in with a blade-shaped hand from the side. Thinking next about cranial nerves 2 and 3, this is our optic and oculomotor loop. And you can look at this with the light reflex. And you guys have all done this a million times, I'm sure, but you can hold the patient's eyes open. And then cranial nerve 2 is your sensation of light, meaning they can perceive the light. And then cranial nerve 3 is your ciliary response so that you can have pupillary constriction. So that actually tells you a lot about cranial nerves 2 and 3, even though you think like, oh, I'm just checking pupils to make sure that they don't have any sort of herniation syndrome, which is great and totally good. But you're also checking cranial nerves 2 and 3 to make sure that the part of their brainstem is working also. Do make sure that if a patient has had any sort of pupillary dilator medication, I know sometimes we have patients who have had an ophthalmic exam. The ophthalmology folks will have put drops in their eyes. Take a note of this. Sometimes it's noted in the chart, sometimes it seems to not be. Other things that can cause pupillary dilation, you guys are familiar with the trauma reasons, but also medications can do this. Sometimes if they've had any type of inhaler type of medication that's kind of been blown in their face, or sometimes scopolamine patches that will get put on, the patients will rub it and then they'll rub their eye and then they'll have pupillary abnormalities that thankfully aren't a brain problem. They're really just an eye problem and medication problem. Thinking next about our cranial nerves 3, 4, and 6, these all go together for how we control our eyes. So all of these cranial nerves have to work together for you to have smooth pursuit of your eyes in both directions, side to side and up and down. And so you can check this a couple of ways in patients who can't respond. Ideally, you would just be able to ask them, look left, look right, look up, look down, or follow your thumb. But in this patient population who's has a decreased level of responsiveness or is unresponsive, they're just not going to be able to do that for us. So what you're going to need to do is forcibly hold the patient's eyes open and then see if they can track you, like we talked about before. If they can't track you, you're going to want to try to move their head from side to side. We call that doll's eyes, and so you can see if they can stay locked on you with their eyes. Even though you're moving their head, if their eyes are staying locked on you, that gives you information that their eye muscles are all working together and suggests that cranial nerves 3, 4, and 6 are working together also. So cranial nerve 5, our trigeminal nerve, usually we would just test patients and see if they had sensation in all 3 of their distributions. You'd say, can you feel me here, here, and here? Good. This patient population is not going to be able to tell you whether or not they can feel you. So if you do want to test cranial nerve 5, you can place your thumb or your index finger right here on this like supraorbital notch, and you can gradually apply pressure in that area to see if that cranial nerve is working for the patient. Usually it takes about 10 to 20 seconds to elicit a response. But if you feel on your eyebrow, you can kind of feel that dent. You guys are familiar with that area, I'm sure, from trauma and fractures. But if you feel on that area and you push on it pretty hard, it's not super comfortable. So you would expect to be able to elicit a response from a patient if they were able to sense your pressure. Of course, this isn't a good idea in anybody who has cranial fractures, and I know that your team deals with that quite a bit. Thinking a little bit more about cranial nerve 5 and 7, the way to check these 2 things together is to look for a corneal reflex. And this is what you want to do pretty particularly. So a lot of us, even neurologists, they studied neurologists across the country and asked them like how they do the corneal test, and most people were actually wrong. So I want to make sure that you guys know how to do it correctly if you are planning to check the corneal reflex. The reason this is useful is if you're not eliciting a response or you can't elicit a response with that supraorbital pressure for cranial nerve 5. And if the patient can't activate their face for cranial nerve 7, you want to make sure that these 2 nerves are working. And this is a good way to check the loop. Cranial nerve 5 is the sensation of the cornea, and cranial nerve 7 is the blink. And so both of these circuits have to be working together for you to see a corneal reflex in a patient. So you want to get a small wisp of cotton, and you want to actually put it on the cornea. So I think you can see my mouse. So you want to be really careful to go in from the side. You don't want to go in straight in front of the pupil, because then you're going to be testing a visual reflex, and you want to make sure that you're actually testing a sensation and not vision. Remember, if somebody's coming at your eye with something, you're probably going to blink, even if it's a tiny wisp of cotton. If they can perceive that in their visual field, they may blink not because of their corneal reflex, but because of their vision. So you want to make sure that you're coming in kind of from the side, and you want to make sure that you put that, You want to make sure that you put that wisp of cotton right on the cornea, if you can see here, and not out here on the white part of the eye, because that's testing a different sensation. And then you can see pretty quickly if patients are going to be able to have a corneal reflex and blink to that. Cranial nerve 7, you can also see just if a patient has a facial droop. A lot of our patients who have a decreased level of responsiveness aren't going to be able to respond to commands. So if you say, give me a big smile, they're not going to be able to do that just because they can't follow commands. But sometimes you may be able to see if they have a facial droop on one side, even if they can't activate their face. This can be tricky, especially if somebody is intubated and already has the ET tube in place. It can be really difficult to see if they have facial asymmetry. And again, this is something that people may have had Bell's palsy in the past. They may have had an old stroke. You want to note it, but it may not be the most helpful thing on your cranial nerve exam. Cranial nerve 8 is our vestibulocochlear, and so a lot of times we'll just say, like, can patients hear? Check. Yep, we checked our vestibulocochlear nerve. We made sure that patients could hear us well. In patients who aren't responsive, even if you're doing like snaps in their ear or clapping really loud on one side, they may not be able to respond to you. It is helpful if you can see if they like try to open their eyes or try to like look to one side. If you're like snapping in one ear or the other, that can be really useful information. But if they can't do any of those things, looking at the doll's eye response that we talked about a little bit before, by forcibly holding those eyes open and moving the head from side to side, can help you know if their vestibulocochlear nerve is helping regulate their eye movements. So if you move their head from side to side, you're testing 3, 6, and 8. If you're moving the head up and down and seeing if they can keep their primary gaze, you're testing 3, 4, and 8. Of course, for patients who have C-spine injury, this isn't a good option. So make sure that it's safe from a C-spine standpoint before you move their head quickly from side to side. Cold calorics are useful in testing cranial nerves 3, 6, and 8 also, but most of the time we don't put patients through this unless we're thinking about brain death exam. So I won't go into a ton of detail on this, but if we did want to do cranial nerves 3, 6, and 8, we would look for any sort of abnormal deviation or lack thereof to the cold caloric stimulation. Really, normal is looking toward the side where the water is being applied. Abnormal is holding the fixed gaze straight, and this is what we see when we're over in the MICU doing brain death examinations on patients who have severe anoxic injury. If you did that to any of us, we would be extremely nauseated and throwing up. So most of the time in patients who are conscious and we're able to elicit these cranial nerves some other way. We don't want to go to this as kind of a first line. And you can test cranial nerve 4 if you do cold calorics on both sides. If the brainstem is intact, it'll cause the eyes to deviate downward, and warm water will cause them to deviate upwards. Again, this will make all of us super nauseated, so we wouldn't do this to patients who you can elicit these cranial nerve responses some other way. And then cranial nerves 9 and 10 are your glossopharyngeal and vagus reflex. So this can be done with the gag reflex. We're trying to get a patient to cough. If a patient is able to, you can use a tongue depressor or a Q-tip to tickle the tonsils and uvula. In our patients who are intubated, moving the ET tube or the suction catheter can be useful in getting the patient to call for gag also. And then same thing, cranial nerve 10 can be stimulated with the suction catheter down the endotracheal tube. Cranial nerve 11, our accessory nerve, we don't think about it a whole lot. Usually on patients who can respond to us, we have them shrug their shoulders or turn their head from side to side. Obviously, our patients aren't really going to be doing that. So if we wanted to test that, we could take our thumb and 2 fingers as kind of a pincer grasp and really take hold of that area of the muscle and gently twist, increasing pressure for about 10 to 20 seconds to elicit a response. Challenging patients for the trauma situation is patients who have a high-level spinal cord injury. This really may interfere with their ability to assess this. And then cranial nerve 12, you can't assess this if patients can't follow commands. This is one of the few cranial nerves that you really can't do unless a patient can fully participate with you. Thankfully, it's not going to make or break your neuro exam by whether or not you can do this particular cranial nerve. So now we've made it through all of the cranial nerves. We want to think about how to examine other things in the body without a patient being able to respond to us. So one of the things we can look at is motor tone. And the way we do this on the extremities on the upper hand is to hold the patient's hand like you're giving them a handshake and then twist the hand back and forth from side to side and then do flexion and extension at the elbow. This can give you information about the patient, including if they may have any old injuries, if they have any spasticity for one reason or the other. You can also have elevate the whole patient's arm up and down to evaluate the shoulder rotation also. Thinking about motor tone of the neck, you want to make sure, of course, this is okay from the C-spine standpoint, but if there's no concern for C-spine injuries and you're thinking about other things for acute altered mental status, we want to keep in mind things like meningitis, which can present with some stiffness in the neck. So just looking at the motor tone, you can gently grab the head and move it back and forth, up and down to see if there's any increased tone. And you can also move it from side to side to see if there's any increased tone on lateral flexion also. So motor evaluation of the extremities in a patient who can't respond to you can be pretty challenging. And sometimes we just say, well, the patient's unresponsive, which is fine if they are totally comatose and sedated, but we want to make sure that we're not missing something just because a patient can't understand what we're asking them to do, or make sure that we're not missing some movement if we think that the patient has significant difficulties already. So one thing that we can do is to passively raise the extremity. So if I'm saying, Mr. Jones, raise up your arm, and he's not raising his arm, it may be because he doesn't hear me, maybe because he doesn't understand what I'm saying, or maybe because he's super weak and he just can't do it. So one thing to do is actually take the extremity and hold it up in the air and see if they can hold it up after you take the arm or leg and place it there. Sometimes they might be able to, sometimes they might not, but they can be useful in knowing whether the patient's having difficulty understanding you or whether they're having difficulty performing the movement. And then you can do arm and leg dropping test. So sometimes we think about this in patients that we're worried about other things like conversion disorder. This probably doesn't happen so much in your unit as it does in other locations in the hospital that we see, but sometimes we'll take the arm and carefully, but put it above the patient's face and then catch it before it hits them. But that can be suggestive of a conversion disorder if you put it right above their face and they end up going like behind them, or if it drops right down toward their face. You want to make sure that you're careful to catch it before the patient hits themselves, of course, if they are very weak. And the same thing with the leg dropping test, holding the leg up in the air and then seeing if they're able to sustain it or dropping it. And then also response to painful stimulation can give you information about whether or not the patient is actually physically able to move the extremity or not. That does give you information about their motor abilities. You have to decide, and we'll talk about it in a minute, whether it's a spinal cord reflex or whether it's actually a intentional motor response, but it does give you information about whether the patient can move their extremity anti-gravity. And the way we usually think about doing this is giving nail bed pressure. So you can take a pen and provide pretty significant nail bed pressure right there to the base of the thumb or to the base of one of the small toes. It's pretty uncomfortable, and so patients, if they can, they can sense you, and if they can move, they'll usually move away from that painful stimulation. You have to keep in mind if patients have peripheral neuropathy or some sort of lower extremity vascular disease, this may be more challenging in that situation compared to somebody who does not. So thinking a little bit more about painful peripheral stimulation, this is where we use the pen or pencil and provide that nail bed pressure to the PIP or DIP joint to elicit a response. You can also think about central painful stimulation. The peripheral pain can elicit a spinal cord reflex in the tested limb, and that's not really an indication of brainstem function. So while the painful response can give you information about the motor abilities of the patient, sometimes it is just a spinal reflex and doesn't give you information about whether or not the patient's brainstem function is really working or not. So then you can think about central painful stimuli. And these are the trapezius twists that we talked about, pinching the shoulder and giving a good twist, or doing that supraorbital pressure, eliciting cranial nerve 5. You can also do jaw margin pressure for cranial nerve 5, or a sternal rub. Those are all central responses. So that can kind of take away the confounder of any spinal cord reflexes, which can be really helpful sometimes. So when your med student comes to you and says, Doc, I can't do a neuro exam, the patient's not responsive, you're going to say, oh, yes, you can actually. The only things you can't examine in a patient who's unresponsive is cranial nerve 1, smell, we don't care anyway. Cranial nerve 12, tongue protrusion. There's lots of other things that are in that same area of the brainstem that you can examine. You can't do ataxia because the patient's not following commands to do finger to nose or heel to shin, and you can't test their gait. But actually you can do the entire rest of the neuro exam that we just went through without a patient being able to respond to you at all. So hopefully that's helpful to think about and to kind of keep in mind. We do the brain death exam all the time, which kind of goes through each of these things in a modified fashion. So you really can do the neuro exam on people who can't participate with you at all. Next, we'll shift over into some stroke syndromes and some vascular anatomy, but I'll pause for a second and see if anybody has questions kind of on the neuro exam so far in a patient that's not responding to you.
For the gag reflex, I was told that you can stimulate it with like sticking a Q-tip intranasally as well, and it's the same stimulation. And I was wondering what your thoughts were about that, and versus moving the ET tube or something else orally.
You probably do get the same sensation. And if you feel like that would be a more effective test, really anything to kind of tickle that posterior oropharynx to get the patient to elicit that cough response.
Okay.
Do you do that? I've never I've never stuck a Q-tip that far up the nose besides COVID testing.
Yeah, I usually that's what I use for gag reflex ever since somebody told me that. I just thought it was like slightly nicer for whoever I was doing it on, but I could be wrong because I'm not doing it on myself. So I just wanted to see if you thought that was pretty accurate in your opinion.
Yeah, I think that gets to the same like anatomy that you would be irritating to elicit a response.
Okay, thanks.
Great question. All right, so we'll keep going. So digging back in our brain a little bit also for vascular anatomy, really all of our stroke syndromes are reflected by which territory is at risk. Blood clots don't usually pick and choose very carefully of which vascular territory that they're going to clog up. And so we want to think about what the patient looks like and what their symptoms are, and then kind of map that in our brain to which blood vessel could be causing a problem. So the way I think about stroke syndromes globally is whether it's an anterior stroke syndrome or whether it's a posterior stroke syndrome. So our anterior circulation is provided by the internal carotid arteries, which give off the anterior cerebral, middle cerebral, anterior choroidal, posterior communicating, and posterior cerebral artery. Then our vertebrobasilar system, our posterior circulation, also can give off the PCA, the superior cerebellar artery, the anterior inferior cerebellar artery, posterior, anterior spinal, and posterior spinal arteries. So you guys are pretty familiar, I'm sure, with Circle of Willis and kind of like the smushed version of all of the blood vessels in the head. The ones that we think about a ton and that I'll go over a couple of stroke syndromes for is the basilar artery, the posterior cerebral artery, the anterior cerebral arteries, and the middle cerebral artery. These are the ones that we think about the most. You can definitely have problems and stroke syndromes from some of these small ones like the pontine perforators or your anterior choroidal artery. But these big ones are the ones that I would hope to make sure that you guys can recognize kind of right off the bat or have a high level of suspicion in for your patients. You guys can look back through these, but these are some of my favorite slides from an old textbook that I have. I feel like it just gives a really good overview of areas that are taken care of by each blood vessel in the head. So remember, in general, we keep our anterior cerebral arteries in the middle. We keep our MCAs on the outside. We keep our PCAs in the back. That's kind of just the quick overview of where each of the blood vessels map to in the brain. But we'll talk about each one in particular, specifically the ACA, stroke syndromes, and then left and right MCA first. So thinking about an ACA infarct, the ACA circulation really feeds the area that takes care of the contralateral leg. So if a patient has a clot in the anterior cerebral artery territory, we're going to expect them to have isolated contralateral leg weakness or potentially leg weakness and face and arm. Some patients, that vascular territory covers a little bit more of the face and arm part of the homunculus compared to others. You also can have some sensory changes on the contralateral leg, and occasionally people will have an ipsilateral gaze preference and sometimes urge incontinence also. In your population, it may be challenging to know whether this is like a motor problem in the leg, if they have fractures or some sort of trauma, or whether this is a acute stroke that the patient's having, but something that you want to keep in mind. So when we look at the patient's MRI, this is what we end up seeing. So that ACA territory right there along the midline, it doesn't go too far laterally. That's right there in that ACA territory. And that is something, depending on what the patient's like pre-hospital abilities are. This isn't a standard territory that we send patients for mechanical thrombectomy, but it is an area that is possible. Our team, the interventional team, is really adept at taking patients for intervention, and we have sent patients who just have an isolated ACA occlusion for mechanical thrombectomy. So something to keep in mind if you have unilateral acute onset of leg weakness. So MCA infarcts are one of the most common strokes that we see. just based on the vascular anatomy, it's pretty easy for clots to go up straight from the internal carotid arteries and out into the middle cerebral arteries. And because of the diameter, it's easier for those clots to track into that territory. So we think a lot about MCA syndromes. Things if the patient has a complete MCA syndrome that you'll see is face, arm, and leg weakness. The leg can be sustained a little bit just because it's sometimes taken care of by just that ACA territory and not the MCA territory so much, but sometimes you'll see total weakness because you're not just getting the cortical motor tracts, you're also getting the internal capsule, which has all of these territories right there together. You also may see complete homonymous hemianopsia, meaning they can't see over to one side at all. Ipsilateral gaze preference and global aphasia if it's on the left side, or neglect if it's on the right side. And we'll talk about each of these things a little bit more. So just a quick reminder of visual field territories. Even if in our patients that we can't ask them to count our fingers, you can do that blink to threat. And so if the patient has the ability to do blink to threat relatively well, you may notice like, oh, they're blinking on this side, but they're not blinking on this side at all. And that can give you suggestions that the patient may be having an MCA territory stroke or a PCA territory stroke. If you remember back, if you have an MCA territory infarct, you're going to get the homonymous hemianopsia, where you can't see one half of your vision out of both eyes. It's not an eye problem, it's a brain problem. And so it's the same on both eyes. And the PCA territory, depending on where the infarct is, in the optic radiations, or whether it's back here in the occipital lobe, you may still get a homonymous hemianopsia with some sparing of the central visual field. Or you may get a quadrantanopsia, just depending on whether you're on the upper portion of the optic radiations or on the lower portion of the optic radiations. So that's something to keep in mind, thinking about visual fields for these patients. So if this is your CT scan, you're going to expect a pretty total right MCA syndrome. This means that the patient will have weakness on the left side of their body. They'll probably have gaze deviation to the right. So remember, in strokes, you look towards your stroke. So whichever side of the body the stroke is on. So if you have a right brain stroke, your eyes are going to be looking toward the right. Left brain stroke, your eyes are going to be looking toward the left. That's something that I think about a lot, because in the back of my mind, I'm always thinking of is this a stroke or is this a seizure? And you can keep it in mind by thinking about which side of the brain is more active, is how I think about it. So in strokes, for the example of this patient, the right side of their brain is less active. So the left side of their brain is the one that has the activity. So it's pushing their eyes over toward the right side. In a seizure, for example, if a patient had a seizure on the right side of their brain, the right side is going to be more active, and it's going to be pushing the eyes to the other side, to the left. So whichever side of the brain is more active, if you can think about it that way, that's really helpful to me to think about if the active side is pushing it to the other side. So whichever side is more active is going to be driving the eyes the other way. And this is what we see on the MRI for a patient who has pretty complete MCA territory infarct. So thinking specifically about the superior vision of the MCA versus the inferior, this can be a little bit helpful just from a mapping standpoint. So in patients who have the superior division infarct, they'll have weakness on their arm and leg, as well as numbness on the face, arm, and leg. And if the stroke is on the left-hand side or dominant side, you'll most often see aphasia or neglect on the non-dominant side. I will say that a small portion of the population, most of the time it's left-handed people, keep their language on the right-hand side, but most of the population, even 90% of the left-handed population, keeps their language on the left. When we say neglect, we mean that this can be visual neglect, or it can be motor neglect, or it can be kind of global neglect. So these are the patients who have the right MCA strokes, and you take their hand and you put it in front of them and you say, whose hand is this? They'll be like, oh, it's your hand. They won't even be able to really recognize that side of their body. So that's pretty significant neglect for these patients. And then the gaze preference, because the superior division takes care of our frontal eye fields, that's where you get the drive of the eyes from one side to the other, from the superior division of the MCA. Sometimes you can see patients who have an MCA occlusion. It's usually like an M2 occlusion who just have aphasia. And this is something to keep in mind also, because we do take patients who just have M2 occlusions for mechanical thrombectomy. So this isn't something that we want to be like, oh, it's no big deal, they're just aphasic, because this can be a permanent deficit that we could potentially intervene on. And then thinking about the inferior division of the MCA, this is where we can get the Wernicke's aphasia if it's on the left side, and possible complete contralateral homonymous hemianopsia or quadrantenopsia, just depending on which area of those optic radiations you take out, or if you take out all of them. And then you can get other syndromes that are interesting to me, but don't necessarily matter a whole lot in the acute management of the patient. But you can see something called Gerstmann syndrome, which is acalclia, agraphia, finger agnosia, and right-left confusion, which is very exciting and interesting to neurologists. From a trauma standpoint and a surgical standpoint, it probably doesn't make that much of a difference. But if you do see a patient who you're like, oh, that's kind of weird, they can't like count for some reason all of a sudden, or they can't name like the fingers like that you would expect them to, or they have right-left confusion, that's just something that you want to keep in mind. This could be a small stroke syndrome that's not causing other difficulties, but really just causing the patient to have these isolated findings. It's pretty interesting when you see it in isolation because it's not as common as seeing a total MCA syndrome, but interesting nonetheless. So thinking about posterior circulation strokes, and this is the one that I guess I've seen the most in the surgical and trauma setting. Patients will come in with vertebral artery dissections, and I'll show you some pictures here in a second of a guy who I think may still be over onto who had a posterior circulation stroke. This is something that you want to keep in mind, especially in younger patients or in people who have had vert dissections from a traumatic experience. So in posterior circulation strokes, things that we see is motor deficits, meaning weakness, clumsiness, or paralysis, or any combination of these things in the arms or legs, up to total quadriplegia. You can often have crossed deficits from posterior circulation strokes, which makes the exam extremely confusing, right? You might have motor or sensory on motor on one side of the body and sensory changes on the other side of the body. And sometimes we think, it's no big deal. It's just kind of wacky. The patient's confused. But you do want to keep in mind that that actually could be a real finding and could impact how you treat the patient. Sensory deficits, you can have numbness, including loss of total sensation, or paresthesias in any of the extremities, isolated or unilateral. You can have homonymous hemianopsia, ataxia, imbalance, unsteadiness or disequilibrium, or vertigo with or without nausea and vomiting. I find this is one of the most challenging things for patients to explain to you what they're feeling, is this sensation of, is it vertigo, like you're spinning or the room is spinning, or is it ataxia, like you can't stand up straight or you're leaning over to one side, or is it this vague disequilibrium that people kind of describe as feeling like they're like on a boat and can't get their self steady. You can also have diplopia because of a brainstem linking of the eye problem. And remember, we talked about the eyes being able to link together with the multiple cranial nerves working together in the brainstem. If you're having difficulty with this area, you may have diplopia because of ophthalmoplegia. Your eyes aren't lining up anymore the way they should. So the brain doesn't know what to do with information. If one eye is straight and one eye is even slightly out to the side, the brain can't converge those images and makes it quite challenging, resulting in diplopia. And then you can also have just an isolated or reduced level of consciousness. So this is something that your team did an amazing job of actually a couple of days ago that I got to be present for a stroke alert. A gentleman had posterior bilateral vertebral artery dissections and occlusions, and he had an acute change in mental status, and your team responded amazingly quickly and identified that this was a concern for this patient because he had an isolated reduced level of consciousness, and you knew that because of his bilateral vert occlusions that this was something to keep in mind. That could be a severe problem for him. So we'll think first about cerebellar stroke syndromes. We won't go through in a lot of detail like the hows and the whys of all of these blood vessels, but we have three main blood vessels that go to the cerebellum. We have our SCA, the AICA, and PICA. And each of these can give you slightly different syndromes of vertigo or ataxia. In general, much of the cerebellum can give you much of the same things. So if you're thinking about any ataxia or vertigo or acute nausea and vomiting or that feeling of unsteadiness, you want to think, could this be a posterior circulation cerebellar stroke? Sometimes if you just get the vermis of the cerebellum, you may just have like truncal ataxia, or they may just not be able to hold their stuff steady. They may still be able to do finger to nose, but they may just be leaning over to one side and not really be able to right their midsection. So this is the gentleman's picture who's, I think, still in 2A. He was a 60-something-year-old guy who had a motor vehicle collision with a tree and ended up with bilateral vert dissections and occlusions. Did remarkably well, and you guys saved his C-spine, and he's not quadriplegic, which is sort of amazing, but he does have bilateral posterior circulation strokes in the cerebellum. So this is what you want to keep in mind in patients who have vert occlusions or dissections, is that they could go on to have posterior circulation strokes, which could either take out their brainstem or could take out their cerebellum. And this is something that you want to be attuned to in younger patients. A lot of our strokes that we see are in our older population because they have cardiovascular risk factors, or because they've developed atrial fibrillation over the course of their lifetime. But dissections, whether it's in the posterior or the anterior circulation, really can be something that we see in much younger patients and in patients who have trauma. Anytime you have a dissection, you're at risk for closing off the blood vessel altogether. Or if you have a partial dissection, you can have a clot form on the top of that area of dissection. And then when it lets go, it can go up and block up any of the blood vessels in the brain without giving us really any sort of heads up or warning to intervene before it happens. So I wanted to go through a couple of posterior circulation stroke syndromes because these can be a little tricky and misleading or confusing if you don't have them kind of at the top of your mind that you have a level of suspicion for. So lateral medullary syndrome or Wallenberg syndrome, I think it's sort of fun to remember these names, but you don't need to remember Wallenberg syndrome. This is somebody who has nystagmus, vertigo, ipsilateral Horner syndrome, some facial sensory loss on one side. They can have hoarseness and dysarthria, and sometimes the hoarseness is actually what tips you off. This can be tricky, especially if a patient has been intubated and is now extubated and talking to you, and they're having these like other sort of vague symptoms, and you notice, oh, they're still having hoarseness like 3 or 4 days after their extubation, maybe longer than you would really expect them to. You want to keep in mind, could they possibly have lateral medullary syndrome if they have any sort of sensation changes on one side of their body with temperature and pain? This can be evidence of a pica or vertebral artery occlusion stroke. This is what it looks like on imaging. So it's a pretty small territory when you look at it on imaging on the MRI, but it's pretty important. You know, this has, I would consider all of this posterior circulation high real estate territory, meaning that they, that a lot of important information goes through this area, and so it's difficult to just discount it. And if we keep it at the top of the mind, you may have a higher level of suspicion in patients who already have posterior circulation dissections if you're seeing some of these things, like the sensation change on one side or the hoarse voice. Thinking a little bit about the pica infarct, this is the one that can give the truncal ataxia. You can also have limb ataxia if the inferior cerebellar peduncle is affected. And this is remember that pica is a branch off of your vertebral artery, so you want to keep this in mind if you have somebody who has dissections in their vertebral arteries. And this can lead to total cerebellar stroke on one side. The thing I wanted to mention here is that when you see a whole hemicerebellar infarct, you want to worry about cerebral edema and possible herniation for these patients. There's options for suboccipital crani in patients who have cerebellar infarcts. Remember that space, you have the tentorium on the top and you have bones on the bottom, and so there's really not any space to swell. And when the cerebellum starts to swell, usually around days 3 to 5 after the initial injury, that's when you need to worry about any sort of swelling that could lead to herniation and the rest of the brainstem compression. And then the other side of the coin, medial medullary syndrome or Dejerine syndrome, You think about this with ipsilateral tongue weakness, and this is something that you can only see if the patient is able to protrude their tongue. That means that they're conscious enough to be able to follow commands for you. Or over time, you may see lateral hemiatrophy of the tongue on that side. This usually presents with contralateral hemiparesis, meaning like the opposite side from where the stroke is, and also sensory loss on one side. And this can be seen with either the vertebral artery or the basilar artery. So keeping this again in mind in patients who have posterior circulation dissections. And this is our vascular territory for the areas that it impacts. So pontine infarcts, if you have a global pontine infarct, this is where we think about locked-in syndrome. If you haven't ever read The Diving Bell and the Butterfly, it's actually quite a good book, and it was written by the previous editor of Elle magazine, and he wrote the entire book with the assistance of like an aide, and he did that by blinking. So in pontine syndrome, you can have the total locked-in syndrome, or you can have just one area, just depending on how much of your pons you've taken out with the infarct. You can have hemiparesis or hemisensory loss, ataxia, dysarthria, a horizontal gaze palsy, and you can also see pontine pinpoint pupils. So a lot of times when we think about pinpoint pupils, when I see folks in the ED, initially we think about, could this be related to drugs or some sort of overdose or toxic metabolic abnormality? But depending on the rest of their exam, you want to think about, could this be a pontine lesion also? You can see pontine pupils or pinpoint pupils because of an ischemic infarct, or you can also see it with a hemorrhagic infarct. So just want to keep that in mind. Complete and total locked-in syndrome can be extremely devastating. This is patients who have quadriparesis. They aren't able to speak. They do have a preserved level of awareness and cognition, and sometimes will have the ability to move their eyes. They won't be able to move their eyes side to side and may not be able to open their eyes. So if you think like, oh, maybe this person could have locked-in syndrome, you want to like elevate their eyes for them, like open their eyes, and then see if they can look up and down. They may not be able to look side to side just because of their pontine lesion, but they may be able to communicate and set up a system with you to like look up for yes, look down for no. And that can be pretty effective for communication. Interesting to me is that they've done studies of patients who are locked in, and they report a much better quality / appreciation for life than I would personally expect. So in patients who are locked in, if they have an acute onset of syndrome, definitely you want to call a stroke alert, because we will take people for basilar thrombectomy indefinitely, unless this has been like a long-standing thing for them, of course. But whether it was noticed 1 hour ago, 5, 10, 24, 48 hours ago, was their last normal, you still want to think about this, because if we don't take them for mechanical thrombectomy, they will be probably locked in for the remainder of their life. And although the studies report that that's okay for a lot of people, it might not be. And if we have an opportunity to intervene, we definitely want to do so sooner rather than later. So this was a story I just wanted to show of a guy who presented. He was 60 something. He had a history of some coronary artery disease, and he was found at home like foaming at the mouth by his wife. EMS arrived, and at that point he was minimally responsive with pinpoint pupils. There was some question of drugs in the past, and so they were like, oh, let's just give him some Narcan, let's see what happens. He actually did become much more responsive at that point. But we were worried about him, and so we did stroke alert him. And if you can look here at his basilar artery, it should keep going right there. And you can see that it kind of gets narrow and then it stops altogether. So thankfully the ED was super astute and stroke alerted this gentleman. And he ended up going for mechanical thrombectomy, and this was his first pass. So you have his vertebral arteries coming up on both sides, and then you can see this total gap right here that's affecting his pons. And so that's probably why he had his decreased level of consciousness, and also why he had the pinpoint pupils. His the top of his basilar and his PCAs were probably filling back from the anterior circulation. But just to show this, that this can be something that you can see in sort of vague situations where you're like, there's sort of decreased level of responsiveness. I don't really know what's happening. Keep in mind that it could be basilar occlusion or posterior circulation in some territory. Thankfully, the interventional team was able to take this patient for mechanical thrombectomy. They ended up stenting his basilar. You can kind of see the little like crisscross checks here. They ended up putting a stent through that territory to open up his basilar, and he actually did quite well. And then the distal basilar occlusion can be perplexing sometimes too. You can see kind of like somnolence or confusion, which is a little bit vague sometimes when we see thalamic infarcts. If you have a total top of the basilar occlusion, you're taking out both of your PCAs, and so you're going to take out both of your occipital cortex, and then you're going to have total blindness. This can be, it's called Anton syndrome, but it's pretty interesting because sometimes people will confabulate, and it's not like they're malingering confabulating, that their brain is just making up stuff because it's expecting to see things, and so it just makes up information that it thinks it sees. You can see that with unilateral PCA infarcts also, when people will tell you that they're seeing like dogs or cats on one side of the room, or like, oh yeah, there were some people walking around over there, when of course they weren't really there, but the brain is trying to create information that it's expecting to see. So this person, this was their their initial head CT. You can see that their basilar looks a little hyperdense right there, but you're like, well, that always kind of looks a little hyperdense. Let's get vascular imaging. And then on the CT scan, if you find that they actually do have a top of the basilar, this patient was taken for mechanical thrombectomy also. They have their nice vertebral arteries coming up. Their left side is more robust than their right. That can be a normal variant, but you see that basilar looks good all the way up until it's totally just not. So this patient had top of the basilar syndrome, went on for complete recanalization also. And then one of the more academically interesting arteries that comes off of our posterior circulation is the arteria percheron. This is something that usually most of us have an artery that goes to our thalamus that comes from each side. So left PCA will give off an artery that goes to the left thalamus, right PCA to the right thalamus, but a subset of the population will have one artery that comes from one side and goes to both thalami. And this is called the arteria percheron. This is particularly challenging because if you have a stroke in that blood vessel territory, you can take out both right and left thalamus, which can cause a decreased level of consciousness, and that can be chronic. So the patient will appear to be asleep, although they may be able to follow some commands for you. They will totally appear obtunded altogether. So academically interesting. Unfortunately, we can't do mechanical thrombectomies for arteria percheron. It's just too tiny. And then PCA strokes, this is where we think about hemisensory loss or hemibody pain and the visual deficits on one side. You can also take out thalamic structures here also, and that's what can lead to the chronic pain syndrome, which can be pretty challenging to treat in the outpatient setting also. Just a reminder of what our PCA visual fields can look like, just like if you take out your entire MCA territory because of your optic radiations, you can take out a whole hemifield of your vision because of your PCA also. If you take out the occipital cortex, you can have macular sparing on, so you may have like central vision, but you may not have the outsides on either side, depending on just what particular territory of the PCA you took out. And that's what this can look like on imaging. So you can have the infarct extend all the way up, really pretty close to where you would expect like seizures to start from. Usually PCA strokes don't cause seizures, but if you get into this temporal lobe area any further, sometimes you can see seizures from this area, and sometimes PCA strokes can actually look like MCA strokes. They can take care of more of the motor and sensory cortex than you would expect sometimes. So keep that in mind, that even if somebody doesn't appear to have any anterior circulation trauma or reasons for stroke, that they could have a PCA stroke that could be kind of mimicking an MCA stroke. So that's kind of brought us to the end of my lecture. I just wanted to make sure that you guys had the stroke phone number. So if you have your phones, take them out, put this phone number in there, 24/7, 365, 733-5641, gets you a stroke neurologist at Wilmington, Christiana, and Middletown campuses. We're not currently covering stroke alerts yet at Union, but that is a plan for future state If you ever need to phone a friend, if you have a question, if you want to talk a case through before you feel comfortable calling a stroke alert, totally do that. We have a pretty low bar for saying just call the stroke alert. If you're worried enough about the patient to like have it cross your mind and think about it, I'm worried enough to take the patient to CT and make sure that there's not an opportunity for intervention that could save the patient considerable difficulties for the rest of their life. So don't ever hesitate to call. I think our team is extremely happy to help and hopefully approachable. If we're not, please let me know. I'll take any questions that you guys can think of. Tan.
Hey, two questions. Sometimes we get trauma codes where we probably suspect more a stroke than a bleed. And the ED sort of handles calling you guys, but is there any particular way, like, do you want us to stroke alert that off the bat or just obtain a CTA head and neck once we see the non-con is negative? Sometimes gets a little confusing.
Yeah, it's probably hard to say what we should do like 100% of the time. If you're worried about stroke, knowing sooner rather than later is always helpful. If you're taking them over for trauma CT, we're happy to like be with you guys at the time. So if you want to do like both things simultaneously, that's totally fine.
Is that what you prefer? Because sometimes the ED airs on calling us when sometimes we get there and it's like an old person with 10 million risk factors. I don't know. Seems like more stroke symptoms.
It seems like more stroke symptoms.
Yeah, I mean, the ED sometimes makes that call for us, who they call first, you or us. And then we get to scan, and it's the only thing I guess we don't necessarily have is the CT that can do perfusion, because it's only certain CTs that we tend not to be in.
Oh, gotcha. I think it's reasonable just to consider it on a case-by-case basis. If it's like an old person who had an episode of loss of consciousness and then they fell and they become a trauma alert before they become a neuro alert, I think that's reasonable. If you find that on like more evaluation that they end up having like, oh, they actually have left leg weakness and that's maybe what caused them to fall, then I think that calling a stroke alert is appropriate. I don't know that it's just hard to say whether you should do stroke every single time. I would just think about like what your level of suspicion is, I guess.
And then with thrombectomy of the basilar artery, what's the success rate? What would you tell families? I know untreated, it's 80% fatal, but.
Yeah. So, I mean, the success of opening up the blood vessel is actually pretty good. Like our team does it a lot. They're pretty good at it. What's always hard to say is how much damage has already been done by the time that we take patients for mechanical thrombectomy. So when I'm having the conversation with the family, I say, this is the best chance that we can possibly give them for any sort of meaningful recovery. If we don't take them, we know that they're going to have a significant disability for the remainder of their life. If we do take them, they may have already completed their infarct, and I may not be able to help them at all. Even if we take the clot out and they've already completed their infarct and their PONS, I'm not going to be able to help them. But I think we think about it as like, if there's any possibility of salvaging any sort of that posterior territory, especially in basilar occlusions, it's probably worth it because we know if we don't take them, they're 100% going to be locked in.
Thanks.
Dr. Gannon, just a quick question about locked-in syndrome.
Yeah.
I think this is mostly coming because it's a personal terrifying fear of mine, but do you ever see, you mentioned how if it's, severe locked-in syndrome, sometimes you can open their eyes for them and they can look up and down. But do you ever have a time when the locked-in syndrome is so severe where there's absolutely no eye movement? At that point, is there any way to really tell their level of interaction or ability to communicate?
Not really. It's if they can't show us any movement, the patients that I've seen who have had locked-in syndrome have been able to sustain that like look up, look down. As far as people who, I'm trying to think of like pathophysiology of how they would be unable to do that. I mean, I guess it's a possibility just depending on like the extent of their damage. I don't think that there's a way to tell, you know. That's a really tricky question.
Yeah, no, that makes sense. I was just wondering if there was something there.
Yeah. I was trying to think about like if there was any sort of like, I mean, EEG wouldn't even help you because they're not having cortical problems, you know, that wouldn't help you know, if people don't have cortical irregularities, that's an EEG is not going to be super useful in telling you whether or not they have any sort of ongoing brain activity. So yeah, if they couldn't move their eyes at all, I don't know that you could say whether they had locked-in syndrome or whether they were otherwise like just globally devastated. If they're not able to move their eyes at all, I would question their like I guess I would just ask the family to think more about what they felt like their loved ones like goals would be. You know, if they can communicate, I think in my mind, at least it's one thing, like a patient can interact with people, even if it's just by looking up and down, they can sort of interact with their environment. If they don't have that capacity, I would want the families to just think really hard about whether that's what their loved one would want.
Okay, that makes sense. Thank you.
Awesome. Well, thank you guys so much for inviting me. I will send these slides to Ruth so that she can distribute them to you guys, and feel free to share this lecture with anybody that you think would be helpful. Thank you guys.
Thank you, Dr. Gannon.
Thank you.
Dr. Gannon.
Thank you.